Hi, my name is Linda. I'm from Scarsdale High School, and my research project focuses on mapping gaps in healthcare access for racial minorities. To start off, the US health system has a wealth of medical resources and unmatched financial capacity, yet it still consistently ranks in the last of the high-income countries in health equity or equal access to healthcare. The US is plagued by healthcare deserts where access to hospitals, primary care, or mental health services are limited in up to 80% of the US, as shown by the map on the right. This is due to factors like societal discrimination and structural racism towards minority populations. At the same time, there is a lack of political will and prioritization at the federal level to enact policy to address these healthcare deserts. The impacts of inequity are fourfold. First, during the COVID-19 pandemic saw Black, Hispanic, and Native American, Alaskan Native patients hospitalized at more than 2 times the rates of white patients and dying at disproportionately higher rates as well. Beyond pandemics, immigrants, especially undocumented ones, are often excluded from public insurance programs, leaving almost 50% uninsured. Not to mention, over 41% of Hispanic adults and 35% of Black adults in the US have below basic health literacy, which is drastically higher than the 9% for white adults. These risks, like lower health literacy, ultimately are linked to things like delayed care, higher ER usage, and worse management of chronic illnesses like diabetes and asthma. Primary care, a critical aspect of healthcare, refers to the day-to-day care given by a general unspecialized provider like a family doctor. Primary care provider density, or PCP density, is a foundational indicator of accessibility in a region's health system. This is because areas with more primary care physicians have longer life expectancies and lower mortality rates, especially from preventable illnesses. Reliable access to primary care then is crucial for timely diagnoses, effective chronic disease management, all of which translate to improved population health. The US suffers from pockets of primary care deserts. Specifically, 8% of US counties did not have a single primary care physician, while 75 US adults currently face inadequate PCP access. Most crucially, racial minorities are far more likely to be located in primary care shortage areas, which leads to my main topic of investigation. While research has established racial disparities in healthcare access at the national level, most existing studies examine either racial composition or provider availability in isolation. Often at coarse geographic scales like the state or country scales, given that the US public health system is highly decentralized with significant autonomy given to states to set their own regulations in health departments, it is often difficult and unrealistic to propose policy changes at the coarse national level and requires a focus on local government. Which is what led me to focus on a single state, namely New York State. It is my home state, and it also reflects broad national patterns because of its rich public data environment, high racial diversity that is projected to increase until 2050 from the graph on the right, and a mix of rural and urban settings, all of which are representative of the broader America. Yet there is a critical gap because very few studies visualize New York State healthcare disparities in ways that are directly useful and actionable by policymakers. Specifically, there is no comprehensive neighborhood level analysis mapping the intersections of race and primary care access disparities across New York State to show which neighborhoods had the worst disparities and should be focused on. That leads me to the goal of my study to utilize epidemiologic mapping to investigate how access to primary care correlates with racial composition across neighborhoods in New York City. The objective is to highlight urgent hotspot communities where there is a high minority population coinciding with limited primary care access, as well as success models where diverse communities have relatively strong access. Ultimately, I hope to offer actionable insight for health departments, funders, and community organizations in seeking to allocate resources more equitably. To do so, I utilized publicly available data, specifically the most recent 2021 5-year American Community Survey, which is the census data, to obtain racial and ethnic composition and total population sizes by census tract. For some context, each census tract contains about 4,000 people, which translates to a few blocks in urban areas or a few square miles in more rural areas. and then use the CMS National Plan and Provider Index, which contains all publicly registered hospitals and providers, including like their location, the type of practice they're in, and their provider IDs, which allow me to specifically filter for primary care provider categories. Also, I used other census data files in order to map or use as shapefiles for R, which is my main tool for data analysis, sorting, and mapping. I don't have time to go into all of my code here, but the image below is representative of what an R portal looks like and the output of a map. So for my overall workflow, I began with some statistical analyses. The main goal of statistical analyses was not to generate new data, but to validate the completeness of the data that I obtained in order to confirm alignment with existing studies. To do so, I conducted correlation tests and correlograms to look at the differences or the correlations between racial composition and primary care access so that it is consistent with disparities seen in previous studies. The most specific part of my project that offers new insight is the mapping part, where I get neighborhood specific. To do so, I took all the primary care provider addresses and geocoded them to tract level geo IDs, which are census tract IDs. So essentially, I looked at which providers fell in which census tract or which neighborhoods to then calculate a provider density for every neighborhood and whether or not people in that neighborhood were experiencing no primary care or delayed primary care. With that, I use bivariate choropleth mapping, which is a heat map that overlays the correlations between two variables. In my case, it is access to primary care and racial composition. And then I split that into 3x3 tertiles, essentially creating a 3x3 matrix, which we will later see becomes the key for my map, which is very standard for a bivariate choropleth map. So after the initial statistical validation, I found a statistically significant positive correlation between the percentage of racial minorities in the area and the percentage of adults who experienced delayed medical care. There was also a significant association, but a little bit less, for no usual source of care. When we look at the correlogram on the left, we see that there is a little bit of variation between the specific minority type and the amount of access they have to primary care. But for the main results I'm going to be presenting, I'm going to be focusing on a combination of all racial minorities available in the census data, which include Black, Asian, and Hispanic populations. So here is the final map that I produced with the 3x3 matrix key. It is the top is a overall image of New York State, while the bottom is a zoom in of New York City. With the help of a software called Kepler, I was able to create a zoomable map where you can zoom into any part of the map and get specific to the census tract and click on it to show the data for each census tract. But for presentation's sake, I focused on two general images to show the patterns that I observed. So I'm going to draw your attention to the dark blue areas, which are legend cells 3-3, which we saw concentrated in urban neighborhoods such as the South Bronx, Central Brooklyn, Buffalo, and Northeast Rochester. These dark blue areas indicate high racial minority populations and high rates of lacking primary care. These populations can be historically uninvested, often overlapping with red line tracts, public housing, and undercapitalized health facilities within the densely populated urban areas, all driven by systemic racism and long-term underinvestment, and represent hotspots with structural issues that need immediate attention. Yet, I also saw variation within city areas. Specifically, urban areas included light hued teal, which are 3-1 and 2-1 areas, meaning that there was a high racial diversity, yet comparatively more access to primary care compared to some other urban areas, and that included West Manhattan, Northwest Brooklyn, and parts of Queens, for example, in the bottom image. This reflects good access to primary care despite the presence of moderate to high minority concentration. This intracity variation is likely due to intersecting factors like higher income, employer coverage, and high concentration of outpatient clinics, which are most notable in areas with high social economic status, introducing other variables into the equation. Moreover, the pink to purple, which are 1-3 and 1-2, concentrated in rural tracts. These are areas that have very low access to primary care irrespective of racial composition and mostly concentrated in central upstate in western New York. These likely indicate problems including aging populations, limited transportation, clinic closure, and resource shortages. This reinforces the need for tailored responses specific to each neighborhood and not an overlying response that assumes the disparities are due to racial disparities. Moreover, the bright teal areas, or 3-1, serve as model areas, like Flushing, Jackson Heights, and Nassau County. These areas have high levels of racial minority presence, but comparatively less delayed care. These could be the results and outputs of well-operating safety net systems, multilingual health clinics, and strong culturally competent provider networks, all of which can be further studied and modeled after to fix the hotspot areas. By identifying urgent hotspot tracks, I provide actionable information to policymakers in state and local departments of health, nonprofits, and funding programs. Each of these stakeholders can act on the data differently. DOH can address structural barriers by revising zoning laws or improving transportation to clinics in hotspot neighborhoods, while nonprofits can focus on health literacy, employing community health workers, and offering multilingual education, while funding can redistribute or re-incentivize primary care providers to enroll or employ themselves in rural areas in need of help. In the future, I would like to overlay additional variables like income, insurance status, and provider locations to isolate the drivers of delayed care and produce my original data on immigrant data, which is not covered in publicly available data due to the undocumented status of many immigrants. And I would like to expand this mapping to more states and regions with this now reproducible map model that I've enacted for New York State and use it as a predictive tool. Here are my references, and I encourage you to take action today if this issue resonated with you or you have access to volunteer opportunities near you to help with these health disparities. Thank you.